Good afternoon, ladies and gentlemen. Please join me in welcoming our webcast viewers. My name is Fred Mifflin, President of the Canadian Club of Toronto, and your host. Viewers, thank you for joining us today. Our club is known for its ability to provide a forum for leading public, business, and political figures to share their ideas with us and to challenge our thinking. Through our programs and activities, we offer access to great thought leaders from here at home and around the world. This afternoon's panelists exemplify our mission. Before I formally introduce them, here's a snapshot of a few of our upcoming events. On Monday, May 1st, Canada's newly appointed ambassador to China, the Honourable John McCallum, Canada's former immigration minister, will speak at our podium. And on Monday, May 8th, Ontario's education minister, the Honourable Mitzi Hunter, will speak about 21st century learning for Ontario students. To order your tickets or to learn more about the club, please visit our website at canadianclub.org. You can also join the conversation via Twitter and Instagram by following us at CDNCLUBTO or by using that hashtag. I want to express special thanks to today's event sponsor, Borden Ladner Gervais, represented by Patrick Hawkins. Thank you for your generous support. I also want to acknowledge the youth and young leaders who are with us today thanks to Life Labs from Ryerson University's Faculty of Community Services and Ryerson University's Health Services Management Program. Welcome and thank you for joining us. And now our panel. Healthcare. It's a subject that affects all of us. We're patients of a system that's becoming more and more complex and increasingly challenged. With Canada's rapidly aging population, the need for innovative approaches to health promotion and disease prevention and management is acute. This problem was addressed recently in the Naylor report released this month. At its core, it stated, "What needs to be done to modernize Medicare is no secret. How to do it is the challenge." Our panelists today will help shed some light on this complex issue and the future of patient-centered healthcare. Dr. Brett Belchetz is a practicing ER physician and co-founder and CEO of Maple, the live online and video chat platform that connects members with physicians. He's also a senior fellow at the Fraser Institute and works as an on-air medical expert for CTV. Dr. Brendan Frey is the CEO and co-founder of Deep Genomics, a co-founder of the Vector Institute for Artificial Intelligence, a professor of engineering and medicine at the University of Toronto, and a senior fellow at the Canadian Institute of Advanced Research. He's consulted for several industrial research and development laboratories in North America and England, and has served on the Technical Advisory Board of Microsoft Research. Dr. Peter Pisters is the CEO of the University Health Network. He previously held a number of clinical, administrative, and leadership positions at the MD Anderson Cancer Center in the United States. The cancer surgeon has a particular interest in the use of digital technologies and artificial intelligence to enhance quality patient care. Our panel today is being moderated by Dr. Elaine Chin, who's the founder and chief medical officer of the Executive Health Center and TELUS's chief wellness officer. Elaine is a North American trailblazer and recognized expert in personalized medicine. She's also a health leader in residence at the Odette School of Business at the University of Windsor. Now, as you can tell, our panelists and our moderator are all underachievers, so I hope you can bear with that. As I mentioned earlier, there are Q&A cards on the tables in front of you, so please fill out any questions that you have or comments, and one of our staff will collect them. So without further ado, Elaine and panelists, welcome. The Canadian Club of Toronto's podium is yours.
Thank you. Thank you, Fred. And thank you all for coming, and on behalf of the panel, welcome to all our guests today. So It's a pleasure for me to be moderating this event, and as Fred said, we are all consumers of healthcare from the moment we are born until all the way to the end of when we die. And along our journey, we try to figure out what we should eat, what we shouldn't eat, what is the right thing to do for activities, how many steps should we take, what wearables should we have, and then with innovation and research, we're going to discover that magic pill that will keep us forever young. So we're going to talk about how to achieve that. That will be the ultimate innovation, I think. So I'm going to try my best to keep this tight. And so I'm going to start by talking about innovation in healthcare from the perspective of asking each panel what Steve Jobs has once said. He said, innovation is the only way to win. So I'm going to ask each of them to give me a 1 or 2 minute answer about how they would define innovation, and how is your organization's innovation a way to win. So Peter, Dr. Pisters, you're actually my boss at UHN, so you get to go first, because I don't want to get fired.
Okay, well, it's great to be here.
Thank
you
you
very much, Elaine. And I guess you can tell by looking at us which one of us is the hospital executive. So, just in thinking about a lot of the challenges ahead, we know that we're dealing with tremendous demographic changes that are happening in Canada and really in all OECD countries. And other people have pointed out that the age at which Canadians are aging is highest amongst OECD countries right now. That poses a great challenge to us, partly because Japan and Korea have already crossed the finish line. And we have to really grapple with the reality of what people are calling the silver tsunami, as we're going to be seeing a tremendous burden, tremendous demand coming forward. That's going to put a premium on innovation. And this is occurring at the same time as what some people think of as the fourth industrial revolution, as we're moving past steam, electricity, and computers, and we're moving into a new era defined by artificial intelligence, blockchain technology, machine learning. And our challenge will be to figure out how to integrate that, how to manage the job disruption that's associated with that. How are we going to embrace the fourth industrial revolution with compassion and empathy that really defines healthcare?
Thank you. You're next, Brendan.
Thank you. Wow. So I'm a simple sort of scientist, technology developer, and I have to say that it's overwhelming to think of sort of the big picture in terms of policy and all these different institutions that take care of so many people. So I'm really just going to talk about things from a fairly simple technology perspective. The old traditional health care and medicine era was data poor and hypothesis driven, which means you ask a question and then you try to get the answer. You conduct a couple experiments to try to get the answer, a couple tests or collect a couple data points. The new era of medicine is going to be data-rich and information-driven. So it won't be hypothesis-driven. The patient will come to you with a data-rich environment, and we're going to need systems that can take that data and come up with an information-rich solution for that patient. So that's basically what's going to happen. From a technological perspective, the only technology that mankind has that can convert large amounts of data to actionable information is artificial intelligence. So the future of medicine will be governed by artificial intelligence. I believe that very strongly.
Thank you. So let's just put some reality into innovation and
Well, so first of all, I'm going to say that when it comes to innovation, healthcare is the laggard of every single industry that we have around the world. So I would venture to ask everybody in this audience, do you bank the same way you banked 10 years ago? Do you order food to your home the way you ordered food to your home 10 years ago? Even transportation, if you book an airline ticket, do you do it the same way that you did it 10 years ago? I would say to all of those questions, the answer is no. Technology and innovation has transformed every single industry, but the way you see your doctor, the way you see a nurse, the way you get your blood test drawn, has that changed in the last 10 years? Has it changed in the last 20 years? I'm going to say the answer to that is probably absolutely not. You are doing the exact same things. I would even venture to say If you look at a picture of the average doctor's office from 50 years ago, from 60 years ago, from 70 years ago, and you look at that encounter, it would look identical to what you do in the doctor's office today. And so we have a vast and overwhelming need to innovate in healthcare the way that we've innovated in every other industry because the need is so pressing. Here in Ontario, our population grows by 1% every single year, yet our spending on healthcare goes up by 3%. And anybody who thinks that that is sustainable is delusional. And the only way that we're going to fix that is to change the way that we deliver healthcare, and the only way that we're going to do that is to innovate.
Thank you. So we're going to go and start now and talk about healthcare policy in Canada, and I promise you that I'll keep this brief. But I agree with our panelists that when we had our call together was that the healthcare policy is going to affect how we innovate, and that is actually quite fundamental. So I'm going to put it in a quick context. In 2015, some of you know that there was a panel that was chaired by Dr. David Naylor, who has been the past Dean of Medicine and then the President of the University of Toronto. And his team interviewed a lot of stakeholders across Canada, did a lot of research, and provided a report card to then Health Minister Ambrose and gave her some recommendations. And more recently, as Fred alluded to this month, the Canada's Fundamental Science Review report, also chaired by Dr. Naylor, called for greater coherence and financial support for fundamental research. So this group made a series of 35 recommendations, and one of them included an increase in funding of $1.3 billion in the budgets of 3 granting councils, the Canada Foundation for Innovation and their related entities over the next 4 years. So I'm going to let Peter start with this, and so what we're going to do is he's going to put it into context, and then I'm going to let Brendan and Brett briefly add value to the conversation.
Okay, I guess to put it in the best macro context, we need to compare ourselves internationally. If you look at the investment that Canada makes in R&D as a percentage of GDP, we're under 2%. We're below the OECD average. And we're far below countries like Israel, which is over 4% of GDP. And we're really behind countries like Taiwan and Finland. So we've got to really take lessons from Israel, Taiwan, Finland, and also look south of the border at some of the lessons that we can take in terms of indirect cost recovery to really understand how we can propel innovation and research here in Canada.
Yeah, so do you have some highlights and pet peeves that you liked about the report and what you didn't like? Let's share it with the audience because they haven't read it yet, because I tried to haul through that yesterday night. It was long pages.
Well, I would encourage everybody here to at least look at the executive summary, which does provide an excellent overview. I think one of the biggest areas that we have to think about is the investment in infrastructure for research. Right now, much of that is being bootstrapped by private capital, and it creates a model that's really not sustainable. And we have underinvestment of government in the infrastructure for research and the operating costs for research. So if we look at it in the pure Canada to US example, you can see that in NIH grants, government grants for research, you can have 50% of those grants towards indirect costs and towards salary support for scientists. Those two things are now on the backs of private capital that comes through, in our case, through hospital-based foundations. And that creates an over-reliance on private capital to support research and creates a degree of fragility in our environment that the government needs to recognize.
Well, we call UHN the big house. So doesn't the big house get all the money? Don't you have some more money than somebody out in the burbs?
Well, I think that our challenge really is helping to cover the indirect costs. When we look at our space requirements, where we have nearly 1 million square feet of research space, the indirect costs to cover that, the heat, the light, the maintenance, cannot come from the Ministry of Health. And so we're really relying on periodic grants, the CIF granting mechanism, or CFI funding, which is inconsistent and incomplete, to support that. And that creates a model for us where we're really going back to private capital to cover the indirect costs of research.
It's really mind-boggling to realize that Some of you don't know, that may have you seen that the Humber Regional Hospital on 401 in Kiel is the first digital hospital in North America, and we need to be really proud of that. And they were talking about creating a new garage, and they saved millions of dollars in prevention of lost heat and air conditioning, and we don't think of it like that. So that's an innovation. So thank you for that. I think you have a few things to say about research and funding, so
Yeah.
I'm going to let you rip.
Sure. So I was a professor at the University of Toronto for 15 years, and I still have an appointment there. But I spun out this company, Deep Genomics, to focus on building AI technology to detect and cure genetic disease. And the vision really is imagine a world where there's no fear of genetic disease. And the reason I spun out the company is 15 years at the University of Toronto, wonderful time, great research, an excellent network, including UHN. But at some point, I realized I needed my group to be able to innovate in a way that was quite different than what you do in a large research network and research environment. And so that's why we spun out Deep Genomics. We don't need to worry about publishing papers. We publish a bunch of papers in Nature, Science, and Cell, but we can focus on doing what we want to do, which is help people. And so I do think there's an important place for innovation, and that needs to be recognized within this environment of research. So I totally support the idea of building up our research capability, and we just need to make sure to have different ways of encouraging innovation. In terms of policy, again, I'm not a policy expert, and I certainly don't have a lot to say that's very wise on that. But here's my intuition. When I give talks about what Deep Genomics is doing, I frequently have individuals come up to me after my talk and say, I'd like to give you my personal genetic information. I went to 23andMe, can I send you my data file? Okay, so this issue of patient confidentiality, that doesn't exist when the patient is talking to the scientist or the engineer who wants to help them. So I think in terms of policy, we need to figure out a way to connect people with their personal information that they really care about to the scientists and engineers who really care about helping those people and people like them. And connecting a really direct bridge is going to be crucial going forward.
Maybe I can just add to that a little bit. I mean, I think when you look at the levers that government has, you have tax incentives or strategic innovation policy. And we're far over to the side of tax incentives right now, which is a very blunt instrument to promote innovation. And it ends up really supporting established companies rather than helping startup companies succeed. So that's a barrier. What we need to do is help the government pivot to strategic innovation policy in the same way that other jurisdictions have.
So thank you for that segue, because we're going to pivot to innovation around primary care delivery, but let's talk about how this policy that Peter's suggesting is going to help.
Well, I think Peter makes a very good point. So I think there's obviously the question about the absolute levels of funding, and so Peter speaks very well about the fact that we are way below the pack. So I think there's about 30 countries in that survey that were ahead of us in terms of their percentage of GDP that was going to funding. And so this isn't just the developed nations that are ahead of us. A lot of very small players that can afford this far less than us are spending more than us. So we need to catch up. The other side of the equation is we need to make it easier for smaller organizations to access funding. We need to cut down on the red tape. So I can tell you, as somebody that started a small organization a couple of years ago that has been dedicated to building a one-of-a-kind platform, we have not been able to access any government funding to help us build what we had to build. There are programs like SHRED tax credits that are available where the amount of work that we would have to do to be able to prove that we are somehow eligible for those credits, and we probably still aren't eligible for those credits because they're so restrictive, but the amount of work that we would have to do would require us hiring full-time staff to file those applications, and that is something that we as a new company just can't afford. So what you end up, as Peter alluded to, is you've ended up with a system where only very large established players that can afford to fill out these applications ever get the funding, and the smaller, newer, more innovative people are left in the dust.
Yeah, I can actually add to that as well. Deep Genomics, we initially applied for a couple government grants, and then we realized the amount of work we needed to do to secure those grants wasn't worth the percent of the company we'd essentially be giving up by spending all the time on it. We could just go to a VC and get a few $1 million after just a couple days of conversation, rather than spending months and months on a grant and then not knowing for a year whether we get it.
Yes, I agree. So I think that this has helped in terms of not making you fully comfortable, but this is a challenge. So let's talk about the opportunity. So I'm going to now change our theme now to genomics, proteomics, and all other many omics, combined with the power of machine learning, which is necessary to lead us to artificial intelligence, which ultimately can predict health outcomes and what I would call offer prescriptive advice. I got that right. Took me like a whole year to figure out what you really do. So as Fred alluded to, I practice in the space of personalized medicine for over the last 15 years. And I guess what it comes down to is I have all these omics, and more recently with TELUS, I've learned how to use the Internet of Medical Things, and I have lots and lots of data. So my wish is I would like to dump all that data to Brendan so that he can tell me how best to look after each and single one of you, and better still, eliminate me out of the equation and you look after yourself. And that would be the ultimate dream for me, so that you can look after your own health. So I would say that IBM has Watson. I'd like to know what you've called your computer, and tell us a little bit what you're trying to do, Brendan.
So, I can't help but briefly mention something having to do with Watson and MD Anderson.
Please go ahead.
That's okay.
He's no longer there. He's one of us now.
So the MD Anderson had a contract with Watson to use AI developed at Watson to address cancer at MD Anderson. And one of the top people at MD Anderson said, okay, in medicine, there's biology and all the other stuff. And IBM Watson's going to help us with all the other stuff. Okay. So deep genomics is completely the opposite. We're going to help with the biology. So the idea is that how does disease occur? Mutation in your DNA causes something to go wrong inside of your cell. That leads to a toxin, or it causes the cell to not interact with some other cell, or it causes the cell to go crazy and start proliferating. That's how genetic disease works. Now, in my opinion, and this is what I've been working on for the last 15 years, if you want to detect and treat such a genetic disease, what's really important is that you understand all of those molecular processes. You understand the biology. Now, biology is very complex, and it's multi-layered, and there's feedback loops. Biology is very, very complex. We all know that. It's not just some simple correlative relationship between, say, a mutation in your DNA and your personality, right? So biology is complex, and so this is a very difficult problem. It's a very difficult, challenging problem to solve. People have been trying to do this for a long, long time. Now, the approach that deep genomics is taking, and this is also an approach that a rapidly growing number of young researchers around the world are taking, is it turns out, and this is a wonderful thing about biology these days, it turns out that there are all sorts of new technologies being generated that allow us to peer inside of cells and measure what's going on. You can just measure things. You can measure, is there a toxin that's accumulating in this cell? Is this protein not functioning? You can measure, is this gene being expressed? Huge amounts of data sets, exponentially growing amount of data that allows us to measure what's going on inside of the cell. So it's a data-rich situation, and the best technology we have for dealing with that is artificial intelligence. And so what I've been pioneering really over the last 15 years is technology that uses AI and machine learning to build models of how the cell works. Just understand, in terms of machine learning, in terms of a computer system, understand how those different components in the cell work. And now when there's a mutation, we can apply our computer systems to the mutation. Our computer systems can say, this mutation is going to cause this protein to go wrong, and that's going to lead to this disease. So that helps with therapies. We can look at a person's DNA. We can say, you've got this mutation. That's going to cause this protein to go wrong, and that's going to lead to this disease. The diagnostics. And then it also helps us with therapies. Because we have this system, we can use our computational framework to simulate what would happen if we went inside of your cell and adjusted something, which is really how a drug works. You adjust something inside of your cell. And so we can also use our computer system to figure out how that adjustment will lead to a treatment for the disease. So that's kind of in a nutshell, from my perspective, how AI would help medicine. So it helps us with biology, and therefore it helps us with detecting and treating disease.
Mm-hmm.
Maybe I can just add a little practical insight also, that what we're really seeing and thinking about right now is a whole group of different sciences like mathematics, computer science, and biology coming together, and new fields being created like computational biology. Mm-hmm. And when most of us were in high school, you couldn't imagine a day where there would be synergies between your mathematics class and your biology class. And that's what we're seeing happening right now in science, which is amazing.
Yes.
When we look at AI in the practical sense, most of you probably read about radiology and pathology, fields that are already coded in zeros and ones, and the reality that already computers can read X-rays with a higher degree of precision in some areas than humans can. It goes far beyond that. And the example that we often use to illustrate this internally really piggybacks off of Tesla. Probably someone in the room has a Tesla, and when you're driving your Tesla is constantly uploading your driving skills into a database. It's machine learning. And now, 2 years from now, when you download the automatic driving module and you're driving through Northern Ontario and you're approaching a curve and you're reading your novel, your Tesla is looking at that curve and it's saying, I've seen that curve in Barcelona. I know exactly how to handle that. That's machine learning. In the emergency room.
Yeah, I would like to just follow up on that. And I think one of what you're touching at there's an interesting connection between self-driving cars and medicine. With the self-driving car, you can always regain control and avoid an accident if the computer's recommending the wrong thing. And so in medicine, the challenges in front of us are how do we trust the artificial intelligence system? So if the AI system recommends double mastectomy or recommends a therapy which will have nasty side effects, how can you trust the system? And really, if you think about, say, 40 years ago, if somebody had said to you, would it be okay if a computer lands the airplane that you're on? You might have said no, but nowadays the computers are landing your airplanes all the time. And so there's this transition where there's a lack of trust to a place where we do trust the AI systems, and figuring out that path is going to be very important. Really, it involves transparency and the ability of the systems to provide explanations for why they tell us to do what they tell us to do.
Right. If you look at the problems, if you look at the problems in our system right now, if we've been given bad food at lunch today and some of you feel unwell, and you go to our emergency room this evening, you'll see a doctor there, and that doctor has 4 buckets of data: history, physical, lab, and imaging. And they're taking those data sets and they're putting it through one computer. And you have a 50% probability that that computer is on the wrong side of the bell curve. And
Not at UHN.
even at UHN, we have a bell curve. And now imagine a different world where those 4 buckets of data were uploaded into the cloud. They were matched with millions of other people who were actually your age, were on your medicines, had exactly your lab data. And what came out of that were a series of diagnoses and probability assignments. And that would eliminate the problem of the single computer. It would avoid a lot of cognitive biases that we all have, like anchoring bias, confirmation bias, and a whole list of other biases that unfortunately doctors have. And it would put us in a position where you actually wouldn't need doctors there. You could have a nurse practitioner gathering those buckets of data, uploading them, and a single ER doctor supervising 15 different nurse practitioners. So that's a completely different world, but it's closer than we think.
Yeah. Would you like to comment on that? And I'm sure that that's where you want to go with Maple, right? That you're going to eliminate all of us, and the computer will talk to all the patients when they call in.
Well, you know, it's funny. I think just put a humanistic face on it. I mean, I'm a big supporter of technology. I'm a big supporter of innovation. But I'm going to say that in the care that I provide, so I still practice on the weekends in the emergency room, and I'm going to tell you, when we get it wrong in the emergency room, when we make a patient unhappy, when we miss a diagnosis, when there's something that just isn't the outcome that we've expected, it's never because, not never, but mostly it isn't because we made the wrong analysis, we picked the wrong tests. It's because we upset the patient. Our face-to-face interaction went wrong. We didn't speak to them in a manner that made them give us the information we wanted. We didn't act empathetic enough for them to trust us with something that was deep down buried in the history. So for anybody that thinks that we're going to, fully replace that medical profession with computers, I think, yes, they're for sure on the deterministic side of it. In terms of what are the algorithms, what are the pieces of information we know we need to have, how do we make decisions, what tests do we order, for sure. But there's an absolutely huge part of that skill set that I think maybe at some point AI will be able to figure out how to simulate emotions and empathy and to be able to get the right answers. But I hope it's not too soon, because I still like my income and I like my job on the weekend.
Well, people will still come in from train wrecks, so you're safe. I just want to eliminate myself because I'd like to work off the beach. So that's what
But I think the point that we really need to talk about is that we need a different type of physician in the future.
That's right, absolutely.
And that we need to go away from the old model of selecting individuals for medical school. When we went through it, there were two big gates you had to cross. One was the MCAT exam, and the other was organic chemistry. And those were used to screen for the ability to handle the workload in medical school, because medical school was all about memorization and regurgitation. Now we're in a different world, and all knowledge has been democratized. It's no longer in the textbook, it's on the internet, and you need a totally different set of skills. You need to know where to go to get the right information, how to curate that information, how to quality control what you're getting from the internet.
I think there's a good analogy here, which is this idea of cyborg chess, where you know, we now have computers that can play chess better than humans, but the best chess players in the world now are the hybrid, as a person paired up with a computer. And so that's really sort of the top level chess these days, and that's, I think, where medicine will be headed. There will always be certain things that humans are good at, the computers are not. Humans are good at analyzing outlier situations, exceptions. Computers are good at aggregating lots of information and combining that to make a kind of a good overall guess.
That will be a great segue now to our final theme before we start getting any questions from the audience. And so I'm going to now move it back to something that we can all relate to, which is frontline care, which we all access from time to time. And as Fred said, that Brett now does some work at the Fraser Institute, and I just want to just paraphrase something that he recently wrote in a blog for them. So 15% of Canadians have no family doctor, while 1/3 of Canadians with a family physician wait more than 6 days to see him or her for an appointment, even when they're sick. And in rural Canada, almost 21% of Canadians live in rural Canada, while only about 9% of family physicians work outside of cities. So you write the lack of primary care options drives about 47% of us to visit the ER for conditions we know aren't emergencies, because we simply have nowhere to go. And it may not shock you, but if you go to Peter's emergency department versus my clinic, it's going to cost at least, I would say, it's more than $300 a visit. That's just the actual visit. There's the processing. I think it's about $2,000 for an emergency visit when it's all in, versus $30 to $50 visit to a clinic. So this is something that is close to Brett's heart, and he's set up a company. He's put his money where his mouth is, and let's talk about your innovation in healthcare right at the front lines. Let's talk about Maple.
Yeah, so you very accurately described the crisis in access to care that exists in Canada. So a huge portion of Canadians have no access whatsoever to a primary care practitioner. You've talked about the fact that those people who do have a family doctor wait an unacceptable length of time. We're actually last in the developed world in terms of access to care, both to primary care practitioners and to specialists. So Canadians wait longer than anywhere else in the world. And there are no options for them, for the most part, other than the emergency room, which you get to that staggering statistic that 47% of our visits to the emergency room, people are admitting they didn't have an emergency. They came because they had nowhere else to go. And you spoke to the cost of that, the fact that those visits started about $300 a visit, whereas the visit to the clinic costs our system about $33 per visit. So we are diverting half of our resources to visits that cost 10 times as much as they should. And especially in an era where our government has run out of money, where there's no extra funds available for healthcare, we should not be throwing money away. And so it begs the question, how can we deliver care more effectively? How can we take this great pool of physicians that's out there and make them more available to all Canadians, no matter where they are? And especially on the rural side, when I wrote that editorial, there actually wasn't a study available that just came out a couple weeks ago, and I think this was CIHI, I could be mistaken, but a couple weeks ago they looked at the mortality rates from cardiovascular disease in Northern Ontario versus urban parts of Ontario. And in Northern Ontario, mortality rates were twice as high as in urban areas. Now, there's a lot of other determinants of health built into that, but a huge part of that is the lack of physician access to diagnose conditions early and to manage those conditions early. So when we look at the stats actually of physicians in Canada, one of the first things that people will say is, aren't all physicians in Canada working to the max? Aren't they maxed out? Don't they have no hours? And actually, that's not true. If you look at the Statistics Canada stats, only about 50% of primary care physicians in Canada and only about 50% of specialists in Canada are actually working full-time 5 days a week. So there is a huge amount of excess capacity in that physician pool. I can tell you, as an emergency room doctor, when I was working full-time, I worked about 14 shifts a month as a full-time emergency room doctor. Those other 16 days per month, there was no way for me to help anybody. If a case came in when I wasn't on shift, my skills were useless to the community. So we tried to say, how can we take all of this excess physician capacity and allow it to help all of these people that can't access a doctor? And so we built a platform over the last couple of years that basically works like Uber for medical visits, for online care, where any Canadian, doesn't matter where you are, as long as you have internet access, can request an appointment with a doctor. And we have a pool right now of about 60 physicians on our platform where we can provide care 24 hours a day, 7 days a week. Our average wait time for care is 4 minutes. So you need to see a doctor, you put in a request, within 4 minutes you will see one. We're going to expand the platform. We're adding specialists onto the platform later this summer. The outcomes have been tremendous. The patient satisfaction has been amazing. The physicians are engaged. Every day, I open my email box, there's 5 new doctors that want to sign up for the platform because they love this idea of being able to help patients when they previously couldn't help patients. The other side of the equation, and this is something that I think might be relevant to people who run hospitals, is there's amazing data because telemedicine, which is what we're providing, has been embraced very much in the United States because they care about the bottom line and they care about happy patients and happy physicians. So the largest hospital system in the United States, Kaiser Permanente, with over 10 million patients. So if you put that in perspective, that is a hospital with as many patients as the entire province of Ontario. Last year, they did 52% of their visits by video or instant message. That is phenomenal when you think that in Canada, last year, we did 0.26% of our visits virtually. So for all of those patients, 48% of them, they never had to drive across town or hundreds of miles to see a doctor. They never had to sit in a waiting room for 3 hours. They never had to catch the flu of the person sitting next to them in the waiting room when they were only there for a twisted ankle. That is amazing. And so especially in the hospital setting, they have data sets, for instance, for elderly patients. If you discharge elderly patients from hospital and you equip them with 24/7 telemedicine and home monitoring, and the solutions exist and we already integrate with that, you can actually reduce readmission rates for diseases like CHF, COPD, and pneumonia by 75%. And I would say, is there a hospital administrator out there that doesn't want to reduce readmission rates? However, the funding doesn't exist. There is no funding bracket. The cost of us to provide that service is about $1 a day. There is no funding out there to cover a service like ours for $1 a day when we can prevent a readmission to a bed that costs $1,500 or more per day. So there's no question this is the future. There's no question when we see other geographies that this is the way that healthcare should be provided. There was actually a study in the United States where 1/4 of Americans said if their family doctor didn't offer virtual care, they would switch family doctors. There's no question, especially with millennial generations, that they want to do everything through their smartphone and online, that this is the right way to access more people for care. So really the only question is how do we make it happen and how do we bring the funding to bear? Here in Canada so far, unfortunately, there is no funding from the government. It is private pay. Patients who are using our service have to pay out of pocket. The one thing I will mention, and I'm going to shut up because I know I'm talking at length, but the one thing I will mention is people like to say, isn't this two-tier care where the wealthy just have another way to access the doctor? In fact,
I'm going to pause you right there because this is the question, okay?
Yeah.
This is the question from the audience, and it says, are politicians in denial that private health care does not exist in Canada, and why the reluctance to change the status quo to make public and private medicine better? So before you answer it, I'm going to get you to answer it quickly because we've got another one that I want Brendan to answer, and then I want Peter to help because I think because I'm also in that space of what I say non-insured healthcare. So I think we need to stop as Canadians talking about private versus public. It's like what's covered and what's not and how we should change the funding model. So now you can start.
So I would say I could talk about this for hours, but the
Yes.
fact that we have universal healthcare is actually a lie. It's an illusion. We do not have universal healthcare. We have 100% funding for as many doctor and hospital visits as you like, and we have 0% funding for anything else. So you want to see a dentist? Not covered. You want prescription drugs? Not covered. Where I work, which is in Scarborough, which is not a wealthy part of town, half my patients come in, I prescribe treatments, and they can't afford to fill the prescription. So what good is that universal health care to them when they can't actually use the treatments that I'm offering to them? So what we really need to be saying is it the right system where we offer 100% of doctor services and 0% of everything else? Or should we look at what's being done in other countries? For instance, let's look at the United Kingdom, let's look at Switzerland, Germany, et cetera, all of whom vastly outperform us. They spend less money per capita on healthcare, they get better outcomes, better wait times. Even among lower socioeconomic populations, they have better outcomes, better access to care, where their model is, we're not gonna fund 100% of doctors' visits, we'll fund 80% of doctors' visits, but we'll also fund 80% of dental visits, 80% of your drug costs. And I would say that's a much more universal form of care where you're getting 80% funded of everything versus 100% of one type of service and 0% of everything else. And I will say also it's a lie that we have universal healthcare system where nobody has better access. If you know the right people in our system, you'll get better access. And if you've got a lot of money, you can drive across the border 2 hours to Buffalo, get your MRI and get your surgery tomorrow. So we have absolutely two-tier healthcare. The only thing is it's not benefiting the vast majority of Canadians. So we need to change the way we deliver. We need to emulate other systems like the Europeans that achieve far better efficiency and far better outcomes.
Okay, so I'm going to now put Peter on the spot because you do have a challenge because certainly there's so much great innovation going on at UHN. Most of your money is for provincial government and like you said, there's private. So how are we going to bridge this? How are you bridging it? Let's start with you in your role.
I mean, I think that we need to put this back at a macro level again and think about ourselves in the OECD rankings. And where Canada sits right now is number 10. And fortunately, the United States is number 11. And as Canadians, we're hardwired to compare ourselves to the United States. And so we have a degree of complacency that results from the fact that we're better than the United States. Where we should be looking is to the top of the pack. And what we need, I believe, is at the federal level vision on healthcare. And it's been said to me by others, and I'm learning quickly here as I get back to Canada, that you cannot win an election in Canada on healthcare, but you can lose one.
Thank you.
That creates a real problem right now when we need visionary politicians to say we should have the highest performing health system in the world. And the challenge we have is that if we go out right now on University Avenue, the average Canadian thinks that we're in the medal round. They know we're not gold because our politicians would be telling us that we got the gold medal. But they all think we're getting silver or bronze. And they're being deluded when we're sitting at number 10 and when we're talking about the real gaps that exist right now where drugs and teeth are not covered.
Right. Thank you. So I'm going to try and because we have 5 minutes, I'm going to try and merge a few questions together into one, and you get to answer it, Brendan, to start. The question really, I'm paraphrasing, is that so the audience is convinced we need innovation, we need data. How are we going to get there with all of this AI and the adoption? And we talked a little bit about privacy issues, which is one of the barriers. And I know it's a lovely topic, you guys. The word is blockchain. So I'm going to give them an opportunity to talk about it. What would life be like if we didn't add blockchain? Now, really short, okay? Thank you.
Right. So machine learning and AI researchers, what they want is a clearly defined problem, a clearly defined data set, and a clearly defined metric for measuring how well you're doing. And then they can use magic to make it happen, and that's true. Okay, and so the big barrier for us in medicine is taking really what's very, very complicated and turning it into a problem that satisfies those criteria. So in genome biology, we can do that because we're measuring the data. It's all quantitative. It's very well organized, and so that's what gives deep genomics its advantage. In an area like electronic health records, we're confronting much more complex data sets, physicians scribbling notes, and all sorts of different kinds of way of recording information. And so the challenge there is how to take that kind of data and convert it to a form that's amenable to artificial intelligence and machine learning techniques. And that really is a challenge that we're facing, and blockchain technology is one of the approaches that we can use to address it.
Thank you. So this concludes our, believe it or not, our panel for this afternoon. So what I'd like to do is answer a question by closing it for all of us, is that innovation in healthcare is critical now in order for us to create a primary care physician, which is yourself. Not the MD, not the primary care doctor that hangs in a hospital. And we're going to have to use the computer to help us put right information in to let you know whether you're at risk. Because somebody asked, so what do you work on first? So I'm going to take the privilege of being the moderator and say, prevention is key. Don't end up in Peter's hospital. So thank you for your time on behalf of the panel. Thank you for being our audience.
Thank you so much, all of you. My name is Pamela Warren, and I'm a vice president with the Canadian Club. Brett Brendan, Peter, Elaine, thank you so much for all of your comments. What a fascinating and somewhat optimistic look into the future. You're all trailblazers, and we really do admire your commitment to disruption and change in healthcare. Brett, I want to thank you in particular for that very depressing opening visioning exercise that you took us through. And while depressing, it does feel like we're kind of on the cusp of some really interesting change and hopefully playing catch up pretty darn soon. If we do this again in the next few years and have that same vision, it will be truly depressing. I am an optimist, and so I think we're all energized to hear about your individual visions and the innovations that you've shared with us today. So again, we'd really like to thank all of you. And Elaine, thank you for your terrific moderating skills. Much appreciated. Before we conclude, I'd like to just extend another round of thanks to today's event sponsor. So that's Bordner Ladner Gervais. And we'd also like to thank mediaevents.ca, Canada's online event space, and VVC for live streaming today's event. And to learn more about the club, please visit us at canadianclub.org. Thank you again, all of you, for being with us today, and we look forward to seeing you again soon.